Hi everybody, I'm Michael Carisse, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. We've spoken with many guests about clinical and technological trends impacting healthcare providers, but less so about the trends on the business side of practicing medicine. So on this episode, we're going to make up for that by spending our time with Dr. Alexander Vaccaro, an influential spine surgeon and president of one of the largest musculoskeletal practices in the U.S., the Rothman Orthopaedic Institute. The practice treats patients at over 40 locations in Pennsylvania, New Jersey, New York, and Florida, doing thousands of procedures annually. But Rothman is not just known for its size, it also has been recognized for its major investment in research and commitment to academics, perhaps best seen in its longstanding relationship with Thomas Jefferson University, where Dr. Vaccaro is professor and chairman of the Department of Orthopedic Surgery and a professor of neurosurgery. I'm looking forward to learning about bridging private practice with academics, the headwinds facing independent practices, and where spine care is headed. And thanks so much for joining us today, Dr. Vaccaro.
Thank you, Michael.
So we always start with trying to learn more about our guests and what first got them interested in medicine. So what's your story?
So I became interested when I became enamored by my primary care physician. I guess you would call them a general practitioner. When I was 8 years old, and I said to my mom, I go, "Mom, who is that?" And she'd be like, "Oh, that's Dr. Ferraro." And I go, "Oh, he's the best. What a nice man, the way he communicates, the way he talks to people, the way everyone respects him." I said, "I'm going to be a doctor when I get older." And that one doctor had a son that was my age, Greg, and he and I played football. And Dr. Ferraro, I just found he just died. He died at 101, by the way, 101 years old. And I read in his obituary that he had started the Little League football league that I played in. It was called the Junior Raiders in Rivervale, New Jersey. And I went there, and he was phenomenal. He became our team doctor. So he would be in the locker room every day examining all the athletes. And he would teach me about hamstring injuries, adductors, abductors. And I was like, wow, that is the coolest job in the world. You get to go to football games, you get to take care of the athletes, you become sort of like a coach. So I said, I'm going to become an orthopedic surgeon someday. So that's why I became what I am today.
When you were that young, you had figured out orthopedics.
Yeah, but then he became my coach in Junior Raiders, and then he became my high school. He was a high school doctor. He became a high school doctor, which was great.
Yeah. Wow. What a wonderful role model to have so young, you know?
And he was a great guy.
When you got to med school and were getting exposed to all the other specialties, did you ever waver, or you were just on that road?
So I never wavered. So I went to Georgetown and I hung out with all the jocks, literally, let me tell you what you do in med school. In the first years of med school, and it's changed now, by the way, because I'm involved in medical school education. But back then it was 2 years in a classroom and then 2 years in clinic. Today it's different. Today it's case-based oriented, where you start, even in your first year, you'll get clinical correlations. But back then we would have lectures for like 5 or 6 hours a day. So we hired people to take notes, a note-taking service, and we played basketball all day long. So if it wasn't your turn to take notes, we went to the gym at Georgetown, and let me tell you, we became like semi-professional basketball players. Like we would play in Georgetown, had a good basketball team. We'd play with the basketball players at Georgetown, and I'm telling you, we became competitive and great. Now, during that period, I hung out with all the guys that liked athletics, so I said, okay, I'm going to be an orthopedic surgeon. My true destiny was spine surgery. That was my true destiny. And that came when I got into orthopedic residency, and I decided to go in Philadelphia. And then my mentor in my first year was this 70-year-old spine surgeon who would come in at night with me. Every night I was on call, and I'd be like, this guy's like 70. And he's in every night with me, putting people in traction. We were a spinal cord injury center. He was reducing people's dislocated necks. He'd literally take his hands with traction and go clunk and put the head back on the shoulder. And I was like, that's like the coolest thing in the world. Yeah. I'm going to do what that guy does. So when I was a first orthopedic resident, I said, I'm going to be a spine surgeon someday. And that's what I became.
Wow. Amazing. And you also are a sports team physician too.
Yeah, for 20 years, I was the spine surgeon for the Eagles. So we had a lot of good times. And the best part of it, besides getting to know the coaches, the players, the excitement, is that I got a NFC championship ring,
Wow.
and I got a Super Bowl ring
Wow.
with my name on it. So, I mean, I can't even imagine getting a Super Bowl ring. Like, they gave it to a doctor. I couldn't believe it.
Yeah.
He gave it to a doctor. And then in the locker room, after we win the Super Bowl, they passed the trophy around. And who cares about disease transmission? We all kissed the trophy. You remember when COVID came around, you can't even look. I mean, we were like making out with the trophy. So that was a cool experience.
I would bet. Wow. So it sounds like you're sort of living out the dreams you had as a little boy in some ways. So we're going to get into the academic side of things that you mentioned, but first, help our audience understand size, scope, mission of the Rothman Institute so that we can set the table a little bit about what we're going to be talking about.
There's several different types of business models in orthopedics. You can belong to a university. You can belong to a healthcare system. You could be bought by a group that has been bought by private equity. You could be private, single specialty, or private multi-specialty. Rothman Institute is the largest single specialty orthopedic group in the United States. So today, I mean, it changes all the time. We expand, we contract. We have 31 offices. We own seven ambulatory surgical centers. We own 2 specialty hospitals. We have 270 providers, and we cover the 7 divisions of orthopedics, and foot and ankle, and shoulder, spine, so forth. And then we have a non-operative group, and that non-operative group consists of primary care physicians, general practitioners that specialize in orthopedics. And then we have PM&R, physical medicine rehabilitation doctors. So we cover the whole gamut of orthopedics. So that's our size.
And what's the business model in terms of what people are expected to do, how you bill, all those kinds of things?
It's interesting to remember, business and medicine is always evolving. So it has changed significantly up until a few years ago. So it used to be predicated on, to become a partner, you had to demonstrate clinical excellence, you had to do research, you had to publish, you had to teach and educate, and so forth. And you had to demonstrate citizenship. As time went on, and all because of all the, I would say, the pressures of reimbursement, contraction, and negotiations, and the fact that a lot of graduates today are not choosing to go into private practice and choosing to join healthcare systems, and healthcare systems are more stable in terms of what they can pay. And that's an interesting definition. What do I mean by stable? When you join a private practice, it's a risk model, which means you get paid what you bring in. So if the insurance companies pay you less, or if you don't collect the money, you get paid less than. You work for a healthcare system, you get a salary. This is your salary. Here's your salary, $1 a month. So today, students are choosing more stability, and they're going in. So today, only 24% on average go into a private practice like the Rothman Institute. And we've changed our model to be more competitive. Instead of saying, okay, you have to do research, you have to publish, we sort of kept that for those that wanted it. But we said you don't have to do that anymore, because that was like, people were like, oh my God, I might not get, like during COVID, I'll give you an example. We had 2,700 employees, and federal support during COVID, if you had a practice that was more than 500, you didn't qualify for certain things. So we had to put on furlough 26 doctors. Now, I didn't even know what the word furlough meant back then. Just right. All of a sudden we get hit by the virus, and I'm the president, and our expenses were big. We're about 36 million a month. And guess what it went to? Our revenue. It went to that.
Yeah.
Because we couldn't operate.
He's signaling zero.
Zero. We were shut down. So now you can't pay anyone's salary. I mean, literally, we all got together and said, we're not going to pay ourselves. Now, how could you not get paid? We couldn't get paid. I still had my medical malpractice. I still had my staff I had to pay for. I had my rent. I mean, we had everything. The expenses were building up. We took out loans and stuff like that. So finally, we had to say, okay, for the people that weren't a partner, and the partners had to pay the bills. So if you were an associate, we said, listen, we have to furlough you. And they're like, what does that mean? Well, we have to guarantee all your benefits, but we can't pay a salary. Just imagine that. It's the first time ever it's happened. Now, if you worked for a university at the time, you got paid. I mean, all their bond rating went down. It triggered the covenants and stuff like that. But they had money. Private equity could pay. A private practice could not pay. And that's when you saw the collapse of the private practice system, because it just didn't have the support. I mean, no one's giving us money. And the last time something like that happened was 1918 with the influenza virus. I mean, we've never been hit with a medical catastrophe like that. So, we came out of it, and then we had the post-COVID financial challenges where the cost of capital, inflation, all the free money given out. I mean, inflation went through the roof. And all of a sudden, if I paid someone $1 an hour, now I'm paying him $3 an hour. But remember, in medicine, CMS insurances aren't paying you predicate on inflation.
Right.
That's not happening. They're paying you less and less each year. So we had a lingering effect in private practice, but we survived and we got stronger and we're doing great now. But that's the downside of private practice, is that you invest and you take risk. And I believe the risk will pay off. But the most recent graduates are going for more stability. And that's what I've noticed.
So what is your case? You don't offer the same economic stability, but what do you offer when you're recruiting folks to convince them to come?
So here's the benefit. It's the flexibility of our business model. If I take time off, I could take time off. If I work for a university, guess what? I get paid by an RVU. You know what an RVU means? If I'm not breaking a brick, I'm not getting paid. When you work for me, you get paid no matter what, because we collect money. We're an S Corp. We zero balance at the end of the year. You have as much vacation time as you want because you're at risk. But if you work for a university, you've got 3 weeks off, you've got 2 weeks off, you've got 4 weeks off. You could do whatever you want in my practice. If you want to specialize in toenail transplantation, which you can't do as an orthopedic surgeon, you could do what you want with paying your bills. You work for a university, guess what? You got to cover this clinic, you got to cover that clinic. I need you to work from 7 to 5 p.m. So you have the freedom to operate. Number two, you have the freedom to be innovative, creative, and you can develop. You work for university, and how universities work. We own your intellectual property if you develop it during your time that you're getting paid. At the Rothman Institute, you invent a gadget, you own the gadget. You invent the gadget during your time working at the Rothman Institute, you own the gadget because you're a partner at the Rothman Institute. So different universities have like 70, 30%, whatever. So total freedom to do what you want to do. If you want to travel to go to medical meetings, you can do it because you're paying the bills. Now, if you want to develop an ambulatory surgical center and outpatient physical therapy, you can do it. It's your capital, it's your risk, but the upside, the marginal revenue that we build from that and the profit margin is yours. So if you are a business person, if you're self-driven, if you are comfortable in betting on yourself, join private practice. If you don't want to do that and take that risk, you join a university. But remember, a university can change the model. Today they're paying $64 an RVU. Tomorrow they're paying $60.
Mm-hmm.
2 years from now they're paying $55. And that's a problem. That's a problem.
Yeah. I mentioned before, we've got this academic connection, and Rothman has really supported a research function for many, many years. You mentioned that you've backed off that a little bit because of COVID and everything else, but talk about that and how unusual is it for a private practice to invest in research in the way you guys have?
Well, while we were really into it, and we're still into it, but not as much, but when we were into it, we would assign points. You'd get a certain amount of points for a peer-reviewed paper. If you spoke at one of these seminal meetings like the American Academy of Orthopedic Surgery, you get a certain amount of points. If you gave a presentation at an important meeting, you get a certain amount of points. And those points added up, and then you would get paid a certain amount of money. So if you demonstrated productivity, you would get paid. Now, we do that now, but to a much lesser degree. Now, I think you max out at $20,000 or $35,000. You can make an addition if you demonstrate academic productivity. The people that do it are people who love to do it for nothing. Like I love to do it, and I get disappointed when I train a fellow, and we like to brag that our fellowship at Thomas Jefferson and Rothman, we get the top. We take 4 fellows a year. So what fellowship is, if you do your internship, residency, you want to specialize, you do a fellowship. We get the top 4 of the year, and I get so disappointed when they say they're going into private practice. I'm like, my child, I failed my child. I'm so happy when they say, I'm going to go to Harvard. I'm going to go to Stanford. And I'm like, that's my boy. That's my goal. I mean, thank you. So that's what I truly get pleasure out of. And when I see one of my graduates go to private practice and then they don't go to meetings and I don't see them, I'm like disappointed. So I try to select those that are going to dedicate themselves to teaching, research, and education. And I'm usually wrong, by the way. I usually think, oh, that guy's definitely going to do it. And I'm usually wrong. But when they do it, I'm so happy. I'm so happy. So we support it 100%.
What are you proudest of in terms of research that's had an impact on patient care?
Anytime we publish a paper, and I'll tell you the papers that I'm proud of. If we publish a paper that has lasting power, like it's quoted 10, 15, 20, 30, 40 years after it was written, that changes the way we practice, that improves, I'm proud of it. I'll just tell you a few things that Jefferson has done. Alan Hildebrand, my spine partner, with Henry Bowman, demonstrated something called junctional breakdown above a previous fusion. And he quantified it. You have a 1.8% chance, if you have a fusion, of developing arthritic changes above that level of fusion. That has led to developments of motion sparing techniques, arthroplasty. I mean, that's quoted. You can't go to a meeting where Alan Hildebrand's name is not mentioned.
Wow.
Can't go to a meeting. So we came up with a uniform language for trauma. It was called TLIPS, Thoracolumbar Injury Classification System. You can't go anywhere in the world, in the 7 continents. Now Antarctica doesn't really participate as much as we want them to, but because the penguins, the penguins, but you can't go anywhere where that's not being, talked about. So we like to do research that has, long-standing living power that's there for, and we publish, by the way, our department publishes 600 peer-reviewed papers a year.
Wow.
600. It's the ones that have impact and lasting power is what makes me proud.
Yeah. I'm just trying to sort out how you juggle all this. So you're running this enormous practice. You're also a professor. You're also doing a lot of procedures yourself. How do you manage it? How do you do it?
It's like the basis thing. I'm getting better every year. You have to have a stable spiritual and physical foundation. That would be my family. And that would be my spiritual life. And then I work out. So I wake up every morning at 3:30 in the morning. 3:30. I'm in the gym, which is in my house, because everything's got to be easy. If it's not easy, you're not doing it. In my house, I have a gym. I'm on the cycle at 4:00 every morning, which has a computer on it that I do my email. So as I'm doing my workout, I'm doing my
like vocally, you're telling the thing to answer the emails, or you're typing while you're exercising?
Yeah, my father-in-law built a desk. He jerry-rigged. My father-in-law took a cycle and built a desk around it, he's a carpenter contractor,
Yeah.
and I do that.
Wow.
And then if I get my email done, I'll go to my elliptical, and then I'll do my normal CNN, MSNBC, Fox News, NFL channel. I go through the 4 of them, and the second one hits a commercial, I go to the next, and then I get stuck on the NFL channel, and I can't get off it, so I stick on the NFL channel. Unless, of course, they show the same rerun of the same Super Bowl game, then I get bored. But that's my workout. And then after that, my first meeting, after I shower, every single day, my first meeting's at 5 a.m.
Wow.
That's my first meeting with management at 5 a.m. And then like today, I did office hours at a meeting, and now I have to look at 2 surgical centers I want to buy. So I have a management meeting, and then I do a tour of one surgical center, I do a tour of another. And then at 7 p.m. is the best time of the day because I'm taking my wife the Fleming Steakhouse for Valentine's Day.
Every day?
Not every day. It's only Valentine's Day once a year. So, but I go.
So for young docs and students listening to this, how many procedures do you do? I mean, like with all these other responsibilities, how often are you in the OR?
So I'm a busy spine surgeon. So you can look up what the average amount of complex spine surgery is a week. I do 12 to 16 a week. 12 to 16. So I'm a busy spine surgeon. But I do 4 a day. I can go up to 6 a day. I have alternating rooms. So once I'm done with the key element of procedure, I go to the other room. So I miss that whole turnover time, which is like, can be an hour and a half. Yeah. And I got a great team. I got a great fellow. I also educated chief president. I've been doing it forever. I started my training in 1988. So I've been doing it forever. So it, like anything else, the 10,000 rule, 3 things that lead to happiness. Remember this. I tell this to everybody. You have to have a purpose. My purpose is to take care of patients with musculoskeletal problems. You have to master that purpose. So do things 10,000 times or more. So you become second nature to do spine surgery. And 3, You have to have autonomy to do what you need to do with your time. And that's why private practice is good to me. I would not be happy if someone told me I couldn't do this, I couldn't do that, and if it just came a job, I wouldn't be happy.
Yeah.
But again, I'm also not under the stress of owing back $300,000 in school debt, which is a new graduate. I mean, I get it. I get why they want stability.
Yeah.
So I get it. But
what kind of cases do you like to do the most?
I love cases that patients wake up and say, thank you. That's my favorite case. That's my favorite case. But I do everything. I do scoliosis. I do deformity. I do infections, tumor, trauma. The simple procedures are like a disc herniation, which takes no time at all to do. And they wake up and their searing extremity pain is better. So I like a variety. Like if you get into one case, then again, like that routine will get boring. So every week I do so many different things. This week on Monday, I did a sagittal plane flat back deformity, which is T10, thoracic 10 down to the pelvis. The next day, and Wednesday, I did a scoliosis from the mid thoracic to the pelvis. And then yesterday I did 3 anterior cervical cases and 1 posterior lumbar case. So it's just a variety.
Yeah, sounds like it. What's changed the most about spinal surgery since the late 80s when you got into this field?
So I'm going to tell you, this is really significantly changed. Anesthesia became more effective and safer. My age cutoff has changed. I mean, before you're in your late 60s, be careful. Now I'll operate on people up until the low 80s without blinking, because anesthesia is so safe. Before I would blink because of, blood salvage and anesthesia. And now we have these ERAS protocols for getting people from anesthesia without using narcotic exposure. So we've changed a lot of things we do in anesthesia. We don't do operations that don't provide stability. Like the implants I have now give you immediate stability. So you don't have to be in braces anymore. You don't have to be bed rest anymore. You don't have to be in traction anymore. So that has really changed. So the time under anesthesia, and then the products we use in the operating room to minimize blood loss. We have things like tranexamic acid we can inject to minimize blood loss. We have these things called Aquamanus that prevents, it is safe now in the operating room. And then we use navigational systems like robots now for precision care. Like that's all changed. It's expensive, but it's like now it's relaxing. Like I get most stressed out when the technology fails. Like when the battery goes dead, I'm like, oh my God, that's a bad day, because technology really helps us in the operating room.
Yeah. Is there anything coming down the pike that you're excited about? As for the kind of cases you do?
Well, everything's about navigating an instrument, an implant, has the neurovascular structures to protect them. So the things that are coming down the lines are things that are allowing us to see into a patient's body without making an incision in the operating room. So you see the AR, VR, or mixed reality technologies. Those are interesting. The robotic technologies are interesting. These are the things that I'm interested in that are really, really, really great. That's evolving. I'm part of the process of helping develop that technology.
I want to come back to something you said early on, which is, the decline of private practices just across the board. Do you think we're going to get to a point where that's 5%? Do you see that model disappearing? And what are you concerned about?
No, it can't. What keeps us having a vibrant medical economy is the fact that we have different stakeholders buying. If you didn't have private practice advocating for the doctor, the insurance companies would bully the healthcare profession. Because once you work for a university or a healthcare system, you work for a university and you're not out there advocating. So you can't see what's going on in the back end. So if the insurance companies are now lowering reimbursement for a physician, the hospital's interfacing with that. This doctor over here has no idea what's going on. It's the private practice side that has to go to the legislators. It's the private practice side that has to go to the insurance company. Now, the only person not listening, I think, is the government. So we have to get more politically involved in that. And that's why we have our societies, but we have to advocate. And I think that it's the private group that advocates. Because if I was working for like my university and I was getting paid a salary, I'm not thinking advocacy. I'm not thinking, activism. I'm thinking I got to go to work at 9. I'm coming home at 4 and I'm picking my kids up at basketball practice. But if you're running your own practice and you got to make sure that they can't continue to cut the rate because I won't be able to pay my staff, you are actively involved in the financial as well as the business side of medicine.
No, you don't have a buffer. Their exposure is direct.
Yeah, so I think we have to keep private practice alive. And I think, like everything else, I mean, you and I have been around for a while, everything is cyclical. So everyone will join the institutions, will do an RVU, then they'll feel that their voice is not being heard, then they'll do collective bargaining, and then they'll work to get released from that employment so they can go to private practice, and then they'll have to advocate so that, they can get money to supplement their office development for electronic medical records. It's expensive to open up your own practice. Electronic medical records cost millions of dollars. Like all the rules that there are, all the compliance rules cost a tremendous amount of money. That's why healthcare systems can provide that to me at a very small cost if I have to provide it myself. So we'll learn how to develop federations with other private groups where we could talk to each other. We could scale, commodities that we can use together, such as supplies, back office stuff. We'll figure it out.
Hope so. Listen, we only have a couple minutes left. We always like to give our guests an opportunity at the end to provide advice to the med students and young career folks in our audience. What's your go-to?
So we talked a lot about the hurdles, the friction points of medicine. I just want to say, I've been in medicine now since 1983. So I'm thinking back. That's a long time ago. 1983, when I was to Georgetown. I don't regret a day. I've had fun. And all the bad times I've had, I forgot about because I'm having so much fun today. And it is the most satisfying. Like today, I got yelled at by a patient that I had just yelled. The patient was frustrated, yelled at me. I sat there, took it on the chin, and then made the patient feel good. And the patient was relaxed and everything was fine. I love helping people. And I love the feedback they get when they feel they've been helped. And even if you can't help people, which, we're only human, we can only do what we can do. It is one of the few satisfying places to work where you really, really helping mankind. Religion, medicine, what else is there? You're really helping people. We're helping people. And we're not, my mother and I would always talk. My mother used to be a nun, believe it or not. And then she left. She literally was a nun. And she'd be like, you got to help people. Everything you got to do, help people. And I'd be like, my brothers went into business. Mom, how are they helping people? They work on Wall Street. Shut up. Just don't worry about your brothers. But we're doing things that are great in medicine. It's a rewarding profession. You're going to love it. And, we have our headaches, but that's what makes life interesting.
And that's quite a motivating mission. It's starting to make sense why you get up at 3 o'clock, which, by the way, I'm a Vermonter. Even the Vermont dairy farmers would be impressed with that start time. That's pretty good. We really appreciate your time and your wisdom and wish you all the best. Thanks for joining us.
It was a lot of fun. Thank you very much. You have a nice day.
I'm Michael Carisse. Thanks for checking out today's show. And remember to do your part to raise the line and strengthen the healthcare system. We're all in this together.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisethelinepodcast.